without further ado, we'll get started. We're going to spend a little bit of time today sort of orienting ourselves to you all. So, if you have, and you can answer this quietly, you don't need to push any buttons or anything. But think about this question as we get started. Like, how many of you all have deployed an emergency department reduction or diversion strategy that's using some form of technology and delivering either clinical returns or financial returns? And so I like to set that stage just as a precursor question, because I think some of what we'll talk about today will really separate what the market expects from, ED reduction and what people have actually deployed. And the way I think you can differentiate what the market expects and what people have deployed is based upon, are they delivering value? And the value can be measured in clinical outcomes or financial outcomes. So let's first start by educating everyone around sort of what is the problem? Like, why does emergency utilization or inpatient admissions, why has that been such a focus for everything having to do with value-based care, whether it's the ACO, which was formally legislated in 2011, or the 50-plus CMMI, Centers for Medicare and Medicaid Innovations program that have, created about 50 or more innovation supporting, reductions of the ED in the emergency department, in the inpatient utilization. And a lot of it comes down to just dollars and cents. Many people in the United States will use the emergency department for non-emergent services. We actually clarify in our own software 10 or 11 different types of emergency events that occur. So obviously they're urgent and emergent, they're primary care treatable, they're avoidable, and other clarification or classifications of those kinds of visits. But the reason that this problem is such a paramount problem in the healthcare ecosystem is because often patients will find their way into this setting, and it's the front door for a significant amount of spend. One of the things that you're calling out here is that across, 100 total persons per payer, you're seeing sort of 40-ish as the number of emergency visits per 100 enrolled in each payer. And that in and of itself isn't the cornerstone of this problem. The real problem is that about a third of our total cost comes from inpatient hospital expenses, and almost 18 million, or sorry, more than 18 million of those visits convert out of the emergency department. So it is a gateway to many, many things that happen inside of the inpatient setting. And Medicare with the ACO and Centers for Medicare and Medicaid Innovation have targeted this because it's not often, just the perverse incentives that might exist inside of how revenue is made in certain parts of the ecosystem. It's patient behavior, it's access behavior, it's difficulty of getting transportation, it's difficulty of getting resolution. So this isn't painting the hospital as the evil empire inside of the ecosystem. It's really just that it's a system set up with lots of entry points and lots of gateways that in many different markets, there really just aren't, better services to be captured. There's a lot of bias towards using the emergency department or the health system as the anchor to our care. And a lot of those things as a challenge to sort of the Medicare world, especially, have significant cost. There's a 5% rule in healthcare. 5% of the patient population consumes 50% of the spend. And so if you think about that 5%, almost all of their care, or a big chunk of their care, will be, Part A hospital spend. This is, again, not an attempt to sort of point blame or chase that the problem lies on the shoulder of healthcare administrators that own hospitals and an integrated delivery network. It really is to say that there is a real need for us to evaluate this particular entry point, because it does have, like I said, 10 or 11 different meaningful classifications about what emergency use really is. Were they treatable in primary care settings? Were they avoidable? Were they readmissions through the emergency department? Like, there's all of these things that allow for us to sort of, create indicators for the kind of care that you could support these patients through if you wrapped around sort of a set of services. So what's the solution? I don't know why this slide wants to keep going forward. I know why, because this was the first slide for a build. So I'm going to stop just for a second, go back one slide. Give me 1 second. So the solution to this problem isn't just, knowing that this is a problem. If we're transparent about the real value of what solutions for emergency department utilization are that can have a real impact clinically and financially, there has to be this real-time nature to it. There also has to be predictive analytics. So real-time nature means that within a handful of seconds, you can know that an event is happening. So events can be mini registration. This is when any one of us who walk into the emergency or get ambulanced into the emergency room, conscious or lucid or not, have our health plan card and our driver's license handed over to the intake staff and the admission staff. Those access and patient financial management teams will do a 270 and 271, which is really just the first alert we can pick up. This is a request for Medicare or other payers to validate that the current insurance that's on this person is active and that there are going to be likely reimbursement steps to be made by that payer for this particular patient type. So that particular real-time event of querying the patient for authorization is called a mini reg in systems that work in real time. And so those systems will be able to fire that, hey, this patient that you have care responsibility for under the ACO or as a hospice patient or in any kind of risk-based arrangement. And I picked a number of different scenarios there because we're going to talk about them in our case studies in a few. But it allows for us to know that a patient under your management, a specific patient in a kind of care that you have total cost of care responsibility for, like hospice or like ACO patient populations, it allows for you to know that things you didn't expect to happen are happening. And you can get involved as soon as you're aware of those alerts firing. So that's the real-time alert part. The predictive analytics is because you're paying attention to the utilization patterns of patients, you can start to predict who's likely to be frequent flyers or familiar faces in these emergency departments. And you can start understanding why. Is it a transportation problem? Is it an access problem? Is it an education opportunity where there's a bias towards using that type of service because one time in 1983 they solved a problem similar? It's literally those kind of things that will help you sort of dig through and make predictive analysis of. And then lastly, if you can imagine, you can add this social determinants component to the equation. You can start understanding at the individual level and build a whole person approach to those proactive management solutions. It'll literally help us as we think through building our programming at the provider services level, at the wraparound services level. It'll help us realize what are the problems the patients are facing so that we can meet them where they are and deliver something of high value. So again, I'll share my screen in full screen again because I think we can see them a little bit better. But I wanted to make sure we talked about the problem and the solution. The next thing I would tell you is this is a solution that has component parts. So the health information exchanges have been around and they're very, very mature in about 20 states across the United States. So I picked a couple of examples. This is the state of Florida. I'm headquartered in our business in Jacksonville and personally live in Northeast Florida. And so we as a business started our footprint here amongst this particular HIE that is consistently grown and is really well saturated to support the patients and the communities within the state of Florida. This is a good piece of technology. It allows for us, like I described, to understand those MIDI registration events. It allows us to understand whenever there's an admission, whenever there's a transfer. So think about like you start in the gateway to the hospital through the emergency room, the mini reg occurs. That's the request for authorization to the health plan. We know about it. We can start reacting there. Then there's the admission into the inpatient setting from the emergency room. We know about that. We can act before and after that admission. Transfers are harder to manage. So once someone's in like a med surge floor and they elevate up to ICU or down to step down and then back to med surge, often we can't do a lot to drive the patient interaction, but before they admit and where they admit and then after they discharge is really where you can start separating signal from noise in the technology. So In this particular example, this is now a point-click care company, but was originally built in the state of Florida as Audacious Inquiry. The state of Florida went to bid, Audacious Inquiry won that bid, and they now use that technology to drive all the health information exchange capabilities. So this is an example of a very saturated market where most of the state is covered, not only across the hospital settings, but across post-acute, including hospice, and other really important sort of levers for you to drive your approach to ED reduction and diversion. Another example that's really, really saturated is in Colorado. Again, this is a company that was built as CoRio, but has also just gone through a merger and acquisition, and they're now operating not only in Colorado, but I think they're in Arizona or New Mexico now as well. But our experience with them for the longest and most time has been in the Colorado market. So again, in that market, not only are they covering, over 2,000 entities, giving us real-time admission, discharge, transfer notices, including the mini reg events, including the things we can act upon. But they're also thinking through like who else should be in the mix so that we can get not only these real-time events, but we can give other data that would help organizations really start to build predictive analytics. Like it's not only what did happen, like how can I get involved in real time, but how can I get a pre-emergency department strategy built or a pre-acute strategy built? And so you'll see that health plans are getting involved specifically to try to drive product development. And think of product from an insurance perspective as like additional services. Like if your problem is transportation, we're going to provide you with Lyft for healthcare, specifically to support you as a member so that you don't use the emergency department. And we're going to get you to diabetes clinic or the heart failure clinic, specifically to support you getting the kind of care that's causing an exacerbation that leads you to end up in the emergency room. So there's a lot they get to work on based upon the real saturation that's happening in these markets where, like in state of Florida or state of Colorado, there really is such a great saturation. And now it's about putting the signal to noise ratio together around what patient journeys are happening and how could I wrap services around those patient journeys to further augment the use of care in the appropriate settings and potentially sidestep a lot of those avoidable or primary care treatable services that end up happening inside of the emergency department. So one of the things that we've recognized is that in order to be able to do what the nationally scaled ACOs require, or the nationally scaled health plans require, or even organizations that are in multi-states that happen to cross from one state or one region where HIEs are saturated to another, that there's had to be a bit of a network effect. We've been working on this problem for over 7 years. We connect in 20 different HIEs that are at the state level. And then we connect to the aggregators. So you may know them. Point Click Care owns Audacious Inquiry and Collective Medical today. So we connect to both the legacy organizations plus through a relationship with Point Click Care, we connect there. We also connect with Bamboo, which was formerly Patient Ping. We connect with Experian. We connect with others that sort of play this aggregator role. And so when you think about if you're building an approach that you want to have this one size fits all, being able to listen to all the different technologies that are sending their information out as almost as dial tone. Like I want to be able to say, hey, I've got a patient in here. I'm reaching out to let you know. This is the first step. You've got to have saturation to cover where your patients may move. And we think about moving, especially living in the state of Florida, there's a lot of snowbirds that are here for parts of the year. Almost half of the year they're here, and almost half of the year they're in a state where the temperatures are more appropriate for the different times of the year. So we have to cover, especially with our start being in Florida, we have to cover much more of the United States. So we again, about 7 years ago, began wiring together all of the dial tones so that we could have a really strong network to cover the entirety of the United States. And what that gives you the opportunity to do is to start really getting good at preventative measures. So you're always going to have to react to the things that surprised you. And the way we sort of think through delivering value when you're surprised by an encounter in a mini reg event in an emergency department or a discharge that you need to wrap around services for so they don't readmit, we have to be able to know those things in real time such that we can do certain things that require real-time attention. So I'll give a real world use case, and we'll talk about other use cases later. So we in the state of Florida support every type of care, including things from traditional primary care inside of a clinic all the way up into and through hospice care. So one of the unique things that hospice knows about its population is that they've trained that population and all the carers around that patient to know that, hey, call us first for whatever's going on. We can get a nurse out really quick. Even with that training, often a family member may come in around like Thanksgiving or some other holiday, and then, oh my gosh, she looks so much worse than I expected. Let's get her to the emergency room. So she's been on hospice, being served at home. Every other family member has been managing this according to the hospice deliverables, and now there's an ambulance out front, and she's getting, taken by ambulance to the emergency room. As soon as that emergency room event happens, even if no one calls that hospice number first, one of the greatest things that happens is hospice in most markets have contracted beds with a hospital. So in an ACO world or health plan world, that is a phenomenal piece of knowledge to act upon. So we wire hospices to know that what your patient population looks like that's being served at home. If they present in any emergency department, as an example, then your case managers will be notified as soon as the mini reg occurs, because what can happen at that point is the case manager from the hospice will outreach to the case manager in that ED, that emergency department, and say, hey, Mrs. Smith has been brought in. We're aware of it. As you know, we have contracted beds for general inpatient services there. So instead of having her revoke hospice and then you getting a lesser amount through that revocation for any inpatient care, let's actually track her into one of our GIP beds and support that as the paradigm. So we just moved from what's typically $4,000, $4,500 a day down to $750 a day, but give her the ability to access GIP services, general inpatient services through this relationship, truly just by listening to that real-time event that happens. So that's a great scenario for anybody that's a health plan or an ACO to think through, like, okay, I can wire up some of my organizations that I'm constantly watching how they perform in these contracts for cost of care, and really start selecting hospices that have hospital bed contracts, that have the ability to offer this sort of services, and that pay attention to their admissions, not just react afterwards. Like, this can literally be parts of the journey that happens. And we see about 60% of the patients that enter the facility through this way actually get diverted to the appropriate bed and have the lowest kinds of costs versus a standard revocation, live discharge from hospice, and then all the hospital services that can follow on. So that's one example of just a real-time event notification that you can track. The other things that you can do, obviously, are you can predict how your population is likely to use those services. So there's a couple of behaviors that become really, really impactful. One of those is looking at the meds that are onboarded for a patient. So we watch in most of our patients that are really wired for inpatient and ED reduction and diversion, we watch how compliant they are with repeat meds, because it is a very early indicator for them having an adverse medical event, which will often land them in the emergency department. So about a third of the United States emergency visits are due to a patient turning on without maybe doing med reconciliation completely, or turning off without weaning a certain med that they're on, and they'll start to feel pretty lousy, and that'll trigger the event for the 911 call. And now we're sort of in the mix. So we can literally watch the compliance of meds that are onloaded for a patient and onboarded for a patient as a repeat med at the NDC level, at the literal pharmacy level, and know when things are being filled according to the number of days to fill and how many pills in each fill. And so you can know with fairly clear eyes how many of these patients are going to end up in that third that caused the event that it literally drives them into the emergency room. And then lastly, you can make probability discussion or decisions. You can truly analyze data and start deciding through the lens of analysis how probable are admission and readmission likelihoods. So we do this at scale across the United States, these three things. So I mentioned a real-time one. I mentioned like how do you look for future ones, and then how do you predict probability so that you can, when you build a program for ED diversion, you actually know how to gate which cohort first, because they have the highest likelihood of this kind of outcome. They should get the attention first, because you're never going to have enough resources to do it for everyone. So you want to be able to focus the energy and the attention of that supportive care to the right patients. So use cases that are sort of the top of mind for folks, like again, these are really impactful things that should inform how you build your emergency diversion and redirection sort of programming. So think through what data do you have available. And you can do some of these literally without any data other than the admission, discharge, and transfer. So the ones you can specifically and completely do without any other data type. So you can be a hospice out in the market, you can be a traditional primary care out in the market, you could be an ACO, but focusing on this admission thing without interrogating claims. And you can have the ability to start defining a real-time alert and monitoring approach, which allows you to take advantage of, almost all 50 states. About 90% of the population in the United States is covered under our network. And you can have the ability to say, okay, I'm going to be very clear-eyed on what I'm going to focus on. I'm going to focus on those mini-reg events, and I'm going to focus on discharge. Mini-reg events because I can impact what happens in the emergency department. Discharge because I can get them right back into my setting of care and supportive care services, so we don't have the really expensive readmission that happens within 30 days. Again, there's some penalties that the hospitals pay if they readmit for the same diagnosis within 30 days. So often you'll see the hospitals, for two reasons, chase even more spend in that next encounter. The first reason is I didn't find what was the cause enough to diminish the symptoms, so they're back again. So good medicine says I need to investigate more through more diagnostic work, but also I'm going to have this penalty, so let's bill above. So those two things kind of work in combination. So a readmission is really, really expensive in the United States. So that's one thing you can turn on truly just by having us turn on this ADT network for you all to do that in real time without any other data. The other things that you can do in sort of this, in no other data that's required from like claims detail to do, specific predictive capabilities, is measure and marry your events that happen in real time to the kinds of SDOH data that's at the neighborhood level. So if I know, for instance, that this particular person has issues with access, then I know that they live in a neighborhood where that access is limited largely because of housing security. Housing insecurity is a problem. I know I need to manage those patients very differently. And so one of the things that you would want to know is, okay, if housing insecurity is a problem, part of the reason why they may literally go to the emergency room is to just try to have room board and an eval. Like literally, if I can go get an evaluation, I could potentially get a med surg bed. I've not had I've not slept in a place where I'm comfortable for a handful of days or weeks. And this is a methodology that you can say, okay, how do we get these people where that's the trigger for this emergency event to have some form of community service being provided to them? Again, this is the population health level, so we can very much help you guys think through, like, what do you build there? Other things that we see is really starting to marry these things into transitions of care. I'll show you in a case study later where this drives not only outcomes from a clinical perspective, but real financial benefit. And then the last two items that I think are tied together to these technologies, but also require claims to be brought into the view, is the ability, if an ACO is actually literally knowing, in almost every ACO this is the case, they know that their number one spend is the inpatient spend. They know that a third of their patients come through the emergency department. One of the things you can use the claims data for is to literally predict what's the probability of an admission and readmission, and how much is this patient potentially not managing their meds. Those two things alone, if you just focused on them, would really cut down the number of events that happen in the highest cost sites of service. And so those are examples of where those things tie off really elegantly to dollars. So again, this is sort of crawl with these two here, the real-time alert and the SDOH. This is walk, starting to turn it into supportive care services. And this is run, how do I predict things and start to ensure that I can make the dollars I'm investing here on the analysis and the kinds of care delivery, I can make them up in shared savings and incentives tied to these kinds of use cases. So what we do in our own sort of language is deploy all of this in what's called an acute reduction module. So it literally allows for us to wire these things together, recognize what data you already have access to. If it's nothing today, then we can bring truly with getting a roster of patients on a service line that you have at risk, whether that's hospice, whether that's guide, if you're in that kind of program, whether it's an ACO of standard reach or high needs. We'll know who your patients that are at risk, and that is a qualifier for us to be able to get real-time admission discharge transfer notices across all those markets we just talked about. And it really will allow you to start looking for opportunities to further engage this population who are almost always in our work, almost always the familiar faces, that 5% that consume about 50% of the year are the ones that get managed through this kind of solution. And it's not truly just like, hey, here's a dashboard, everyone has one. It's these things have to be actionable. Like they need to have a true model of care in support of them. So the hospice example is a super clear one where if you're an ACO today and your hospice benefit spend is being tracked month over month over month, one of the things to track it for is how much of the events are occurring inside of the hospital where revocations, live discharge, incremental spend occur. It's not just, to look at the line item of hospice and say it's gone up or gone down. It's to literally build a model of care that says, well, if we turn on hospice case managers into that service delivery, they can actually push these persons that hit the emergency room into contracted beds. That in and of itself is a huge savings. If you're focused literally on the post, like after discharge events, which most primary care does, then you can literally wire up things for transitional care management to be tied to things like, as you know, hey, I want to see these patients within the first 2 days in some form or fashion. That can be a virtual visit, it can be a telephone call, it can be a mailer. If you meet that criteria, lots and lots of research showcases that that's a good event for you getting them scheduled back for med reconciliation because think they're going to get discharged with those home meds. Often they're only for a short period of time. So you need to understand what did they discharge as discontinued meds? What did they discharge with as the new regimen of meds? Often patients don't understand they're not supposed to take their original meds. They start taking their meds when they get back home, and adverse medical events can occur. So like getting those persons talked to within the first 2 days can help ensure we don't have adverse medical events from those drug-to-drug interactions that are likely to happen. So again, we measure things like when did this discharge occur? How many hours since that have your teams reacted in such a, with an urgency that can sidestep a lot of these particular problems? And the really cool thing is these solutions have become so sophisticated, you can know the discharge diagnoses, at least at a working level of diagnoses, even in that those admission type notices that are occurring, right? Because the initial workup will give a working diagnosis, and then at discharge, even if they discharge from the emergency department, we'll often see ICD-10 codes related to what the discharge diagnosis was. So lots of detail can be gleaned even just from what's being captured in these admission, discharge, and transfer notices. So a couple of case studies just to make this a little more real. This is an organization that actually spoke on our behalf at Medical Group Management Association. Now it's been October of 2021, so we're coming up on 3 years since they spoke about this particular topic. But what you'll notice is the Florida HIE, again, underneath the covers is point-click care and audacious inquiry. When they first started, they were doing things daily. This is now all real time. And so real-time alerts are firing, and this group is literally chasing transitional care management as the only inflection point where they hear the noise and define a signal. That noise of the alert is taken directly into the hands of care managers as a text message or an email message. They click the link in either of those two, either text or email message, and it takes them directly into that dashboard. And then they work those patients to get into primary care within 7 days is the goal. And they've been able to create an incredible amount of impact. These dollars flow from two things. They flow from the incremental transitional care management billables that are happening, but they also flow because those particular contract types that have risk related to global spend pay a bonus against shared savings. So they know their benchmark. They know what the patients have cost historically. when they wrap around these TCM services, they're sidestepping so many hospital events by having this wraparound and supportive care service, that this is an aggregate. This is their view of how their financials have improved since they've turned on the services related to watching for events they can react to, reacting to those events, and then sidestepping future costs for readmissions into those emergency and hospital settings. So want to be cautious of time and know we're right at the bottom half of the hour. I'll look for questions now. But one of the questions I'll start us off with is, if you could see these kind of this kind of traction from an emergency department reduction and diversion strategy, if they could, if you could kind of have this sort of returns being delivered, how many of you guys would want to deploy a solution like this? And again, there's not a reason for you to react in this, chat. You can't. I'm happy to have you send us like, hey, we're interested. But really, I wanted to start with that pre and post question. Like, do you have something? And then at the end, would you want something that gives you these kinds of opportunities? So I'll open the floor to questions, and if you have any, I'll be watching the Q&A session inside of our chat capability. I have a question here. Our experience with HIEs in our market is that we have to do a lot of documentation. Is a system like yours built similarly? So it's a great question. In many technologies, there is this sort of anchor is often the hospital, and the hospital wants as the hub, they want the spokes to do a lot of documentation. So in our world, whoever is the person that's setting up our system becomes the hub, and everybody else is a spoke. So you're not documenting on behalf of the hospital who has the discharge. You're actually using the real-time notices to actually trigger your own workflow. So in many of the HIEs that are out in the market, you become a work agent for the HIE to be scaled and sort of saturating their own market. And solutions that we deploy, it's much more the market saturated with dial tone. Phone calls are happening about your patient. We're going to be listening only for your patient. And when those things become prevalent in something you can react to, we're going to alert your staff that they actually have an action that can drive a benefit. And so we make you the center of the universe versus you being at the end of a spoke, having to feed data through usually keyboard entry back to the hub. In most cases, those are the hospital systems. And so even if you are an ACO, even if you don't have an EMR as a technology, you can leverage our system specifically to track the patients that are parts of your beneficiary rosters, such that you can know when there's been an event in real time, and then you can parse those down to the providers that are your participants. You can manage some of the calling that needs to happen within that first 48 hours. You can support list generation out of our tool to give your individual clinicians every day at the beginning or end or middle of the day, things that they should know that are happening on that specific dial tone about patients that they have care responsibility for. So it really is a paradigm shift to have you all be the center of the universe versus being one of the spokes that's having to fill out detail about something that's happening to one of your patients. It's a very big shift. It's a great question.